We're going to begin in just a minute. I'd like to do a sound check for those people that are online. Can you hear me?
Yes, we can hear you.
Yes.
Okay.
Shut.
Yep, I can hear you.
Don't connect with video, with audio. Yeah, otherwise we're gonna get infamous.
So we're going to do one other sound check and then I'm going to work for T-Mobile.
I think someone's volume is on their
That's me.
laptop. Okay, perfect.
That was going to be my fault.
He was waiting.
Let's try, Daisy, could you say something? Let's see if we can hear you.
Good morning, everyone. I'm here in the conference room.
Could everyone hear Daisy?
Yep.
Excellent. Well, the folks in the room didn't have to say yes, but okay.
Yes.
Okay, well, happy Monday. Thank you so much for joining. We're gonna jump right in. We had a little technical issues. We're trying not to have that anymore. So welcome, everyone should be on. If you're joining from the room, if you do get on Zoom, there are instructions right behind you, so there's no echoing. And this way, folks will be able to see you better because the picture of the room, you look very, very teeny and you can't really see who you are. Also to participate in the chat and for the whiteboard work that we're gonna focus on a little bit today, that would be great to have your computers. You can look at your computer or it doesn't matter, whatever you'd like to do. All right, so let's move on here. All right, it's October 28th. Sorry. All right, so I think that we went through this in terms of, in terms of some of this, but for folks who are in the room, we have many, a significant amount, at least 1/3 of folks are new. And we want to make sure that people know one another or begin to know one another. So when you speak, even though you may think everyone knows you, please just say your name and your organization affiliation. That would be very, very helpful. And because there are indeed a good group of us, if you're online, you can raise your little hand or just do this and we'll see you also. And for folks in the room, just raise your hand and then we can call on you just so that I don't want anyone talking over one another. So the slides and the minutes will all be available. We'll be sending them to you after the meeting. And just a reminder to complete the evaluation, only takes 3 minutes, it's very helpful. And we really look at that, we talk about that, we send you the results, and then we really try to make changes so that everyone is getting what they need and their voices are heard. All right, so we're gonna begin by everyone introducing themselves. It's a way for us to do a friendlier way of Robert's Rules of Order in terms of our ability to do a roll call, which is required. So I would like the folks online to begin. Last time we began with the people in the room. So this time I'd like for the people online to introduce themselves. So if I call on one person, then they can call on the next person. If you haven't been called, then put your hand up as a sign. Or we'll help you, because at some point it gets hard to keep track of who said something and who hasn't. So anyhow, I'm Palmyra, very good to see you again, and I'm going to hand it over to Regina.
Hi, I'm Regina Birdsell. I'm State Senator for District 19, Hampstead, Windham, and Derry, and I'm Chair of Health and Human Services. And I'm going to hand it over to, Kristen, are you online or in the room?
I'm in the room. Oh. My goodness, I forgot not to. I'm supposed to be the tech person. Anyway, I apologize. I'm in the room as we all just demonstrated, but thank you for calling on me and it is good to be here with you all again. I'm one of the facilitators from Brandeis. let's see, I will call Ann Landry.
Good morning, Ann Landry, Associate Commissioner at DHHS. Sorry, I'm not able to be there in person today, but I'm excited for the meeting and I will pass it over to Trisha Tilley.
Good morning, everyone. I'm Tricia Tilley. I'm also from the Department of Health and Human Services. Also happy to be joining you today. Again, sorry, our schedules are all conflicting today, so I have to do this online. And I'm going to hand it over to Bobby Bagley.
Good morning. Thank you, Tricia. Good morning, everyone. I'm Bobby Bagley. I'm the Director for the City of Nashua's Division of Public Health and Community Services, and the Chief Public Health Official in the City of Nashua. And I will turn it over to Justin.
Thank you. Justin Romanello. I am the Chief of the Bureau of EMS. I apologize for not being there. I was feeling a little under the weather, so I decided to come into the office briefly instead of coming over to the Hospital Association. I will pass it off to Josh Meehan.
Hey, good morning, everybody. Josh Meehan, Keene Housing, and also the New Hampshire Housing Authority Corporation. And nice to see everybody this morning, and I'll pass it over to Ed.
Hi, my name is Ed Shinchell. Speaking of being under the weather, we have a very heavy frost in the North Country. A 4-letter word, a little bit early. I'm from Amanusa Community Health Services. I'm the chief from. Oh, that's right. I have to hand it out to someone. I'm gonna be lazy and hand it off to David across the room because I can see it.
Oh, hi. I'm Dave Nagel. I'm a physician in practice in New Hampshire for 35 years. I'm also the state representative on the board, and I represent the Lakes region functionally.
Hi, I'm Lauren Pearson. I'm the Executive Director for the North Country Health Consortium.
Easy. Good morning. My name is Alice Sekou. I represent New Hampshire Housing Financial Authority, and also I'm the president of the Islamic Society of Greater. Pass it to Phil.
Hey, my name is Phil Sletton. I'm the research director at the New Hampshire Fiscal Policy Institute, and I'm going to try to put it back online. If that's the right way to do it.
Absolutely.
Okay, great. Polly, you called on me last time and I wasn't ready, so I'm going to call on you this time and hope that you're ready.
Thanks, Phil. I appreciate the turnabout. My name is Polly Campion. I'm a former state representative and immediate past chair of the State Commission on Aging, and here representing that group. And I will pass it to, have you heard from Megan yet?
I am Megan Heusler. I am the individual representing community hospitals on this group. I'm from Wentworth Douglas Hospital. I'm a community benefit manager. I will pass it off to Daisy. Good morning, everyone. Daisy Pierce, Executive Director of Navigating Recovery of the Lakes region, and I will toss it to Maggie.
I knew she was going to do that. Hi, I'm Maggie Pritchard. I'm here for the Behavioral Health Association. I run the Mental Health Center up in Laconia and Plymouth, and I am going to pass it to Scott.
And I almost did, so now Kristen, I almost unmuted. So because here we are on the run. Scott Foster, I work with with Whitney Hammond at the Division of Public Health Services, and I will pass it to David Nick. Oh, I'm sorry, David, he's already gone. I will pass it to Rebecca Bryant.
Good morning, this is Becky Bryant. I'm here at Lakes Region Community Services in Laconia, and I will pass it over to Monica.
Hi, everyone. Monica O'Clair. I'm the Chief Strategy Officer for Huggins Hospital, and I represent critical access hospitals on this meeting. And I am out ill, so I apologize. I sound a little funny today. I will pass over to, I am trying to keep track. Has Greg gone yet?
Hi, everyone. I'm Greg Norman, the Senior Director of Community Health at Dartmouth Hitchcock in Lebanon. And Andy, has any of you gone?
I have not. So Andy Hessian, and I'm with the Endowment for Health. And I have to be honest, I've lost track of who has gone. So if you have it, maybe do the raise hand thing. Or did I round us out? That could also. Whitney?
Hi, I'm Whitney Hammond. I am from the Division of Public Health Services, the Bureau Chief of Prevention and Wellness, and I will hand it over to, I think, Jennifer Johnson.
Hi, everyone. Thank you. I'm Jennifer Johnson. I'm a certified nurse midwife and an associate professor in a doctoral nursing program, and I am representing the New Hampshire Nurse Practitioner Association. And I don't know who to pass it off to because I thoroughly lost myself. So Beth Daniels, looks like your hand's up.
Good morning, everyone. Beth Daniels representing the community action agencies. And I too have lost track just a bit.
Ben Chan.
Hi, this is State Senator Becky Whitley. I represent District 15, which is the city of Concord and some surrounding towns. And I'm actually the outgoing senator, so there will be don't know if an additional senator from the district is going to be added, but it's good to be with everyone today. Thanks. Let's see, next on my list, Palmira Santos.
Yes, we looped back around, or who else online has not introduced themselves?
So,
Melissa.
State Deputy.
Hey,
Mel,
everybody. Oh, sorry.
Division of Public Health Services. I work with all the others you've heard of from DHHS here. Thanks.
Hey, everybody. I'm from the New Hampshire Medical Society. My name is Melissa Martinez Adorno. I'm trying to clone myself and be two people, so that's why I can't be there today. And I will, I'm very happy to be here. Thanks.
Let me ask again, who else? I don't want to forget anyone.
Hi, Kim McNamara from the Portsmouth Health Department. I'm representing the New Hampshire Health Officers Association.
Is that everyone? Yay, all right. It was kind of a memory test halfway in for those folks who were, I would have been. So it's great to have everyone, and there's been an issue about quorums. I realize that, and we're working to figure out how we can work around that or work with that, and hopefully there'll be some solutions, and as we get January when things change a bit. All right, so to have a quorum here for Starship, we have 40 members, so we need 21. 13 in person and 8 can be online. My guess is that we don't have that.
Correct. We have enough people, but there are not quite enough in person. I think we're more at maybe about 8 or so in person.
Okay, so do we just split it?
Yeah, exactly.
We just split it. That's what we did. Okay. All right, so again, we're going to work on this quorum piece, and as we get closer to winter, I know when we were driving around here, you know, we really saw snow, even though I denied it, but there was snow coming in. It wasn't sticking, but it was still coming down on my windshield. A little alarming since this is just October. So without a quorum, there's certainly things we can do. We can go forward with what we are doing, which is very, very important, which is sort of operationalizing the general structure of the plan. We'll say more about that. And then coming up on how to monitor health in terms of outcomes. We can also do some designation. So maybe we can't vote something in, but we can designate something. So there's certain language that we can use to sort of more move forward. What we also want to propose in the interim, if we go far enough out, like maybe like in the spring, and we send out some dates, could we all agree on a date that everyone really worked to come in? And then at that meeting, we'll sort of just do a lot of official voting and taking care of things, housekeeping that perhaps we could have done. So that's a thought. And so we'll send out a survey about that if folks are amenable for that. So instead of a vote, I'm just going to say, how does that sound? Does that sound okay to folks? Does that sound reasonable?
It does to me.
All right, thank you. If you're shaking your head and you're not wearing a cat collar, I'm not gonna hear you.
I've seen some thumbs up online as well.
Okay, very, very good. So that is one thing that we can do. And Kristen and I have been meeting with all the members individually. So if you haven't heard from us, we'll be reaching out to you. It's very, very important as we understand your perspective and how it fits into the overall health and well-being for your particular scope. And so we really want to be able to do that. And someone had a brilliant idea. It was either Ed or Dave, I can't remember now. Okay, so Ed and Dave had a brilliant idea. That I don't have my notes here. That might be something worth thinking about is actually make the meeting mobile. So we actually go around the state to the different counties. I mean, I would love to do that. And I've seen that work very well, but I know that's like a real commitment. So I'm just putting that out there. You can have some incubation time to think about it, but that's something that would really help. And then in that community, inviting community members to come and certainly participate in terms of a public forum. If there's an organization that would like to host that, which I guess is when we'll go through the history some time ago, organizations actually hosted that. So let's also think about that in the mix, besides having a meeting that we all agree that we'll travel to, and or this issue of being mobile. So think about that. If you hate the idea, that's fine. You can just let us know that. And so what we'll do is that we won't put anyone on the spot, but we'll also kind of survey you on that, and we'll not share the results of that, whatever you would like. But it really is whatever you would like. Kristen and I were facilitators, but we're your staff, okay? So we will do things to support what the group wants. So, so anyhow, let's move on. So one thing we asked folks to do for homework, and the no pop quiz, all right? We asked folks to review the draft notes or minutes from the last meeting. And does anyone have anything they would recommend to change? We can't accept them, but what we can do right now is take any edits, and then when we do have a quorum, who's gonna remember? I mean, you know what I'm saying? We can't review 10 minutes, but if we know that we, we thought it looked good, then we can do it probably in a more efficient way. So any thoughts you can put in the chat, or you can just let us know, raise your hand. Anyone wanted to change anything in our draft minutes? Thumbs up? I'm not seeing anyone. Oh, we have a thumbs up. Good, using the icon. Okay, excellent, very good. So we're gonna make a note that no one had any edits or any addition to the minutes, and not official, but then we will, when we have a quorum, we'll just be able to sign off on that one. All right, excellent. All right, the other thing on the agenda is the designation of the chair and co-chair. And then we're going to jump right into health status. We'll set a framework for that. We are going to talk about measurement. So this is not the time to snooze or check emails, because we're going to try to make it as entertaining as possible. And then we're going to move to public comment, and then the next steps, and there are about 8 next steps. I'm just warning you now. But we'll be in communication about those. So the chair, we talked about this last time, presides over the meeting, supports membership participation, and then works with, members and different constituents. And there's a time commitment of about 90 minutes. However, Kristen and I support the chair, we staff the chair. So We do the full range of things, including laundry. I think I promised doing laundry to someone. I think that might have been Polly. Polly, am I doing your laundry? Someone I made that promise to. And then a co-chair really supports the chair and actually supports the whole process. And then if someone isn't here, we have someone to step in. And it was sort of quiet for a long time. No one contacted us, no one volunteered. And then we got a volunteer for the chair and the co-chair. So for the chair, Dave has, you haven't changed your mind, have you? I'm not walking the dogs there, I'm telling you. Okay, so Dave would like to continue his role as the chair. And if anyone else wants to jump in, that's fine. Oh, look at all the hands raising. No, it's really very, very kind of you. So what, you want to say something?
I guess,
Yeah.
I was volunteered actually, and, but I accepted, but, yeah, it's because I wasn't here last time.
Yeah, that's what happens if you don't show up.
And that 90-minute per month thing, I've been told that before.
You can.
That never happens.
Yeah,
So.
you can time us. We'll be good. All right, excellent. So if people think this is okay, we're not voting. What we're doing is we're just saying we agree to designate Dave as the chair. Does anyone not agree to that? Maybe that would be the easier one. Or you can chat privately to us if you don't like Dave. I'm sorry. Private chat, just choose Kristen's name.
Looks like we're getting some thumbs up and other supportive.
All right, we're getting smiley faces and thumbs up. All right, you're our designated chair. You have one. We'll get you a badge, at least a nameplate,
I'd like to
okay?
say something real quick.
Yeah, go ahead.
So, this is kind of an honor, it's not kind of, it is, but it's very intimidating honor, because I worked with a lot of you, the last year and a half. And I'm really impressed with everybody that I've met. You guys know way more about these issues than I do. The reason this is exciting for me is because I actually started a nonprofit before I ran for office that had a focus that this group really isn't correct. So I'm hoping that I can live up to your smiley faces and thumbs up. And I'd like to be able to meet every one of you individually, talk to you more and find out what you think we should be doing, where we should be going, where we should be heading, because that's actually how I ended up getting volunteered, because I asked somebody, where is this going? So I said, congratulations. So be careful what you say, I guess.
Well, that's fabulous. So we'll be meeting regularly with the chair and co-chair to help sort of put this all together. And then suddenly we had a volunteer for the co-chair, which is absolutely fabulous. And so that is Ed. You would like to volunteer for the co-chair. Come on. We have it in our notes that you want to.
Oh, yeah, I appreciate that.
Yeah.
And I enjoy working with David, so I think it's sort of fun.
All right.
We have to extend our meeting times to 3 hours then.
I mean, sometimes it's like two kids in a candy store. It's like, oh, and we could build a tree house and then we could build a go-kart. And when it gets dark, we could go catch fireflies. And it is a little bit like herding squirrels when you get to imagining what's possible.
That's why we're here, though. We'll help.
I'd like to have the treehouse subcommittee, like the thing.
Yeah, there we go. I think
We
that's
definitely would need one, yes, that's a good idea.
And we have a zip line?
I think we need to keep that in the subcommittee.
Yes, subcommittee.
Did we tell you this is being recorded? Just letting you know. All right, well, if anyone would rather that Ed not be the co-chair, again, you can message us or, thumbs up if you support. Only support, we're not voting.
You could force me off the road on my way back north.
Any problems with that? All right, I think we have. Yes, all right, thank you, everyone. Very, very good. Okay, it's official. Ed, you are the designated co-chair. All right, we're on the road. This is so exciting. All right, so we're going to do a little review here. Whitney put together this slide as for our last meeting, which is very good. And I may have done a little tweaking, but this is definitely Whitney's product here. And what we talked about is where we are now. If we looked at a map, where are we now? And we're at this phase where we need to define the action that we are going to do regarding the 4 domains. We'll go over that a little bit. And then we have to actually measure how we're moving the needle, how that is going. So that's where we're heading. That's where we're heading right now, is this piece. So we're just going to go through a process where certain things are identified about what to work on, including there may be some really urgent things. There may be some things that we're planting the seed for, some years from now, hopefully not decades. So that's the road that's the road where we're heading right now. So everyone recalls that, right? It was in our slides for the last time. All right, so you remember these 4 domains? So those folks who worked on this for what, 4 years? No, 3 years? Was it 4 years? Long time. I went way back. And so they're very broad areas. They say some general examples. You see a little bit of data. It's not necessarily connected, but it gives some broad scope of what to focus on. And if you look at the 4 domains, there are areas that overlap. They talk about accessibility in 3 or 4. So there's definitely some overlap. Probably the biggest one is under health status and outcomes. So we thought we would begin there. So it's good, for the torturing part, begin with the big stuff first and then, move on to the other stuff, okay? So that's where we're going to begin. And this probably looks familiar. When you all decide on health status and health outcome, you wanted culturally appropriate, trauma-informed support services that are equitable and accessible to everyone in the state, across the state. So, wow, that is just this fabulous lofty goal. I mean, it's easy to get behind that, right? And you broke it down into 2 segments, equitable access. So the full range of care, support, and services for every individual as they try to achieve optimal health and wellness. Also fabulous. I know the word equitable means, as Dave pointed out, different things to different people. So it's not to be a politically charged word at all. We need to use, some neutral words in that, but equitable, just think about it as a mathematical term, right? So the other part to this is access. So these 2 things are sort of the 2 subgroups under this category of health and status. And this access was divided into affordable, high quality, comprehensive, inclusive, and delivered by a person-centered, well-trained workforce. Phew. So these are huge, but they're very honorable and mission-driven. You have to sort of love this. I can't imagine anyone would admit out loud that they don't think this is fabulous. So this is really the wonderful place to start. So where in the world? Yeah, shoot.
Thank you. Like you said, it's hard to not be behind this. But when you said, think about equitable in a mathematical way, I think it's important to define it because at the end of the day, we have all these beautiful words that we put out there. But what that equitable access means, as you said, to me, might be different what it means to Dave or to others. And I would love to know, we need to pass the mathematical definition of it and see what that meant.
Absolutely, yeah, we're trying to take the.
So I guess I would be the contrarian that equal and equitable are not the same, so I would defer away from a mathematical equation.
Yeah.
Because there isn't equitability within mathematics to a large degree. So I could get us all bicycles and that's equal, but David doesn't need a bicycle. You don't like a bicycle. You know, so that's what I think about equal and equitable are different. So I think about equitable, it really is very personal, it's relational. What do you need as an individual? What do you need as an individual that when I meet those two distinct areas, we would agree that you were treated in an equitable manner, although what you got are not the same.
So we can go with the WHO definition or the CDC definition, and that really addresses removing structural barriers and interpersonal barriers. And we can send that out for discussion and then come back and put a definition on that. So it digs deeply into some critical issues that are system barriers with really deep down in terms of racism and discrimination and oppression. But however, this group can define it that way if they want to head down and do that. We work in some states that don't want to use that word, very conservative states. So, but if this group is behind that, then we can establish a definition that is well known.
I would encourage
Yeah.
an infographic, because I'm not certain it's a definition as much as a description.
Yeah, it's a description, yeah.
Because as soon as I define something, I may limit. There's areas I really like definitions, if I want something really black and white. With no variation and ability to misinterpretation. And there's some wonderful infographics that describe visually. When I think about accessibility, I worry about health literacy because literacy connotes visual text. Which is actually in and of itself limiting. It's great to translate things into someone's native language, but an infographic, a visual often communicates, oh, I get it. This is why equitable is different than equal. You can still see people at a ball game, and they all have the same step stool, but not everybody can still see over the fence at the ball game.
So we have one and that we use all the time, that's a visual, for inequity and the structural, barriers and interpersonal barriers or systemic barriers. So we certainly can provide that and have a discussion about that. Yes.
The reason why this is important is you brought up perfect reason. I mean, I looked this up because I wasn't sure what the word actually meant, and this is from Stanford. And they said every group uses the term, but nobody sits down and defines it. And when they finally do, they realize that they're not all talking about the same thing. But the reason why it's important is because number one, it's in statute, and number two, the word appears innumerable times in the website. So we really do need to be on the same page what we're talking about.
I work in the housing market and nothing is different. It's all the same.
Yeah.
And as you said, the definition, or she said it, it depends on people are conservative or people are this. But at the end of the day, either you are conservative or not when it comes to health, it affects everyone. So I don't see the reason for being conservative in this case. It's not because we have witnessed something that happened in China and affected more our community in the United States than any other community in the world. So this is the only place when it comes to health that we should not play with the game or the political behind it or anything, because it affects everyone in the world or in the society or in the community.
So that's excellent. What I think I'm hearing is that we really need to agree on a definition. And so we'll put this top on the list. I don't think we can do it now, but let's put it top on the list for the next meeting. And we can certainly look at that, or we can look at broader ones, that really get into the, the serious systemic racism and the oppression, the really serious issues regarding equity. And I'm going to actually present some of that in terms of the area deprivation index. So you can see what's happening here in New Hampshire in terms of deprivation and some of the real issues regarding inequity. So I will get to that. That's part of the measurement part.
It also looks like we have a comment online.
Okay, go ahead.
It's, Kim, would you like to go ahead?
I apologize. I'm using a phone I'm not used to today, so this is kind of a mini disaster on my end. But this might be along the lines of saving this for a future discussion. But one of the things that concerned me when I read through this, that how are we going to ensure that these statements aren't misused? Because when I read that that services are equally accessible, it brings me back to a discussion with persons with developmental disabilities where that was the thinking, to sort of cut budgets locally and redistribute some funds. At least that's how it sounded. I don't want to speak for anyone, but I just want to make sure that these great goals don't get misapplied somehow in the future, if that's clear.
Okay. And you know what, that's a good point, because the plan doesn't really have a definition section. So I think when these words come up, adding a definition, because we do have to put together a sort of report after a year that goes to the governor and the legislative council or committees. All of us need to put that report together. So I think so this is, I think this is an important issue for other things that will come up also in terms of definitions. All right, excellent. All right, so that goes top on the agenda. We'll have some different definitions that people can play with. All right, so we're going to move on to some broad measurements and root cause. One thing that the plan didn't look at is some root causes, and it's really important to look at root cause. That's part of the contextual factors that drive health and well-being. So we're just gonna take a quick look at this, and we won't spend a lot of time on this in this large group of 40. What we're doing is a subcommittee on measurements specifically. So anyone's interested, anyone can come, but anyone who is very interested in measurement, they can join that group. We already have one volunteer, correct? Yes, correct. We already have one volunteer, which is super, and we'd like more volunteers. And what the subgroup will do is that we'll look at different measurement and then bring it back to the group to consider. And any measurement that we use has to have the highest level of reliability and validity, and we can talk about that not amongst this group, like everyone's glazing over. So we won't do it here. We'll do it in the subcommittee. So we're going to say a little bit about root cause because it's contextual, and then we'll move on to doing an exercise with this health status and health outcome.
When you look at measurements, do you anticipate an assessment criteria matrix that allows us to look at a measurement to ask those questions? The reliability, validity testing, we have baseline data. It covers the whole state, but it doesn't cover the whole state. I worry when I think about data collection, data everywhere, and nothing that's actually.
Yeah,
we're
I don't think
data-rich
we'll.
of information
yeah.
poor as a society,
Mm.
and we as a federally qualified health center submit a plethora
Yeah,
of
you do.
data. So I'm like, okay, so the love of God can at least not create one more metric.
Yeah,
Yeah,
this won't be
census-
new data. This
Yeah.
will not be new data. This will be established data. However, if someone has an intervention that they're doing, that's then they will be collecting data, and that could be an example for the state, such as a promising practice or a pilot. So that can really be worked in. So that's an excellent
So
point.
that's
Now,
more
we're not,
case studies, qualitative data.
obviously, everything is sort of integrated that way. But it does specifically call for measurement, which is indeed measurement. So we will need baseline. So that was great that you brought that up.
Then again, it looks like Kim online has a comment.
Oh, Kim, go ahead.
Thank you. So regarding measurement, one of the things that concerns me is there are small groups of people that are tremendously adversely affected by things. And when we just look at straight data and numbers, that doesn't come through. And if you take any of our vulnerable populations, be they veterans, persons with developmental disabilities, minorities, they were far more adversely affected by COVID, for instance. And so when we're looking at measurements, their numbers in Portsmouth, at least, are fairly small, but the effect on them, on their health and wellness of anything, is huge. So is there some way that during the measurement process, we can measure sort of extent of, inaccess, or just the extent of how someone is affected? Because I think that's really important, and that's what gets missed in so many studies.
Yeah. I think we're not doing a study, but that is absolutely fabulous, and that fits in the framework of the entire plan about equity or inequity. So that is an absolutely fabulous point. When we're working with states or groups, we always do that. You have to look at folks who have a disproportionate effect of something that's happening in health. So everything has to be at that lens. If you look at things in the aggregate, then things get diluted and you're missing some very important details. So that would have to be mandatory. And then if it can't for a particular data set, then that needs to be said. So that is, yeah, so 5 stars for that.
I'd like to recognize the chair.
I'm sorry,
I recognize this is
I was
taking-
a Cub Scout, Boy Scout leader, I always raise my hand, just a topic for future discussion. I mean, we've been looking at disparities. I'm a pain care specialist, and we've been looking at these issues nationally, but as the healthcare system changes, who's disparaged changes also. And I was a little concerned with how limited our list of disparaged populations were. Just as an example, time is money. Now we can spend less time with people in the settings in which we work with them. An interesting group that now is becoming disparaged is actually people in wheelchairs, because they take more than 10 minutes per visit. And the data on that is kind of like in its infancy. But disabled people are huge group of people. They're not a small group. And I just would like at some point that we expand our discussion of who's disparaged. We don't need to do that today either. But
Yes, and your disabled population, and it's in pockets, but we did an overall, this is an overall state, just to sort of, to put that framework in. You're close to 14% of your population, that is, facing a disability or managing a disability. And I understand what you say, that there's some racial and ethnic groups who usually have or most likely have a lot of systemic inequity or a disproportionate burden. And if you break it down, you may not see that. But you're over almost 15% of your population represents that diversity. So that's another piece. You have a growing population of folks who are 65 and older. So someone mentioned that, and we sort of looked at that. There are other issues, and we'll talk about this in terms of another sort of for root cause, is the amount of single parent households and how that affects them. So there are a lot of these indicators in terms of inequity. One thing people always pull is this below poverty level, which is just becoming too old to really make sense. And so we've been working with folks at MIT, and we will show you another calculator that may be actually very good to look at the issue of not having dollars to make ends meet. This is it here. And for the data subgroup, we really dig into this. This is New Hampshire overall, but this can be broken down by county or further, and we can work with the designer of this. This is the living wage. What do you need for a living wage? If you're a single person or if you're an adult with 1 child. So for certain industries, and we didn't do this proportionally, but it's easy to do proportionately. If you're in food service, then that could just be that you're definitely below a living wage. Healthcare support, you're definitely below a living wage. So there are many places or jobs that are, below a living wage. So this is all calculated. Again, it's state level, but we can do it down to the county level. living wage is indeed a causal, it's a core root cause about everything in your health plan. You know, if you disagree with that, you can reach out, but we can show you the science behind this, or we can discuss that in the subgroup. So the living wage is a critical thing to look at. And we also can break down the very specific variables that fit into this. So that is an important indicator, important lens in terms of equity. So we can put that in the mix. And you may have used the living wage calculator before and know more about that. So we can answer some questions about that now, or wait for the subgroup, and then we can move on to other sort of that take a look at root cause. So we can think about that when we're working on each one of the issues under health and health status and health outcomes. Yes, Ed.
Everything I'd encourage when we look at it, and clearly the causal agents are not linear by any means. I think we all be in agreement with that. You know, so I look at this and say, okay, so if this is a key driver, and it probably is. Then I have to think about, is it my realm of control, my realm of influence, or is it outside of both of those realms? So we don't accidentally become Don Quixote, just tilting at windmills, which we can't have any effect. This is important when I think about this from a policy level, whether I'm in DC or in Concord, is a conversational point. You know, because we're in a commoditized society. I don't trade apples for dental care or chickens for my vaccination, so we've commoditized it. Whether or not there should be 2 apples or 3 chickens is we're in a negotiation. We converted that into dollars because it's just too difficult in a bartered world. But I think it is important, if nothing else, it's educational. But yeah, I try to think about, is it my realm of control and how much time?
Yeah.
If it's, can I get it into my realm of control? And how would I do that? Well, I gotta dance out of the realm of influence for people whose realm of control it is.
There are parts to this, Ed, that you can indeed look at, like the cost of housing. There are some things you can work with that are over a period of time. So it's up to you. If there's certain, again, I said the word policy. If there's certain things that you think are out of your control, even though it's a root cause, you can say, oh, we're not going to do that. We're going to do this because it's, easier. We're going to do this because we can make a difference. So those are things for discussion, but we are going to bring up root cause. Yes.
I was gonna say, when Ed, you brought up the data that you already collect, and I don't know if it's above and beyond UDS, but that's a big one, I think. And so I'm actually stealing Scott's idea that he brought up a number of times of like how there's value in just learning what each of us actually collects data on.
Right.
So that then that is maybe what we feel like we have the spirit.
And I can share that, we do community needs assessments, and I think about, what is a relationship with a community needs assessment, with health assessment? If I think like a Venn diagram, if there is alignment, it's probably more happenstance and intent, not because people are good or bad, but maybe no one's thought. If we look at the state health assessment, look at community needs assessment, maybe how much overlap is there when we have an improvement plan at a community level? How well does it align to the state, and how do we communicate that back so that it feeds into the state or identifies best practice? I think my experience is one of the things that's often missing is someone who documents what I call the meta story. People may be more aware of this if you've read books like Codebreaker, which is Dr. Dowdy and Schopenhauer and CRISPR. It's an embedded journalist. It's as though we need someone who's embedded, who's capturing the story and who can see, oh, that's a best practice. And then how do we capture it that someone can pick it up and do anything with it?
I think that's the benefit of a group like this in the very simplest form is that we, at a basic level in the state, we don't really know what each other's doing. So when you get a group like this together and you start putting all of your activities under these kind of huge umbrellas, it makes the picture a lot easier for anybody to look at. Right now, as somebody who's a pretty simple person, I look at this big broad picture that we gave Palmera and her team, and it's like, it doesn't make a lot of sense to me. But I think when you start getting people together and filling their activities underneath these things, it starts to make a lot more sense. And to Palmera's point, it's not about creating more, we don't need any more data sets. We really don't. We just need a better way of figuring out what each other's doing.
Well, as we talk about each of the areas, and we worked on another large project at New Hampshire with, it's just talented people throughout New Hampshire, just like the folks in this community, so there's a lot of resource here. That there are things happening in one county or one community that I would see, well, gee, that's a promising practice. I wonder if someone else would want to learn about that or think about that. That is absolutely this sort of integration and knowledge. That's definitely part of the spirit of the plan. But right now, what this is focused on is not that. It's the larger picture as a way to think about things. It's the contextual piece. That's something that I'm sure it was something you all talked about, but it wasn't like concretely in the plan. All right, so we'll discuss this more at the subcommittee meeting also. Anyone's welcome to that. So I want, okay, comment from Justin?
Yeah, I'll try not to get on a soapbox, but I agree with the points that were made in the room. I mean, I think the benefit of this group is we all have our own data, and it's coming up with solutions that may in our own little silos, we'd come up with a solution that would work for us, but with the visibility of the entire group and how it's going to affect us all, we can come up with solutions that are a couple of chess moves down the road that are going to address everybody's concerns. Because we've looked at EMS stuff and how it's how it compares to chronic disease and some of the other heat maps and related to healthcare. It's fascinating the similarities that a couple of solutions, a couple small solutions can address so many different things. So I agree with what was said in the room.
That's excellent, and I think that that is something. Okay, thank you, Justin. So we talked about the area deprivation index, and that's the ADI. This is very important. Again, you have the equity lens here. And this is made out of 17 different measures from the highest level in terms of validity and reliability. And it takes a deep look at New Hampshire, and it's actually, you can break it down by neighborhood. Woo! And so this is one way to monitor what is happening. And so I'm doing this because there are different ways of thinking. This is exactly what people are saying. In different parts of the state, the issues perhaps look different. There are different interventions for different parts of the state. So the deep orange is the highest level of deprivation. On a score of 1 to 10, it's a 10. The blue areas are the lowest level of deprivation, and that's a 1. Okay? So we can provide some very specific information on this by neighborhood. And the other thing is we have to blow up a little bit of the blue area here, and the map is a little big. So you can actually see the very troubled neighborhoods in part of Manchester, Concord. In terms of the more urban areas, they're not without a significant amount of deprivation. It's just the map, we have to blow it up a little bit to look at that. Yes.
Phil Sutton from the New Hampshire Fiscal Policy Institute. Because I think we're supposed to do that, so my apologies. Who compiled this measure? Are these 17 measures, this is Census Bureau measure?
Yes,
okay.
Census Bureau and the American Consumer Survey. So it comes from many different areas, and we can give you tons of information about it if you haven't used it before. It is usable online. We like to pull the data so we can actually break it down by neighborhood, so that folks, in terms of their planning, know about, well, what we can target. And then as a group, you may want to target, especially with the equity lens, right? The areas that are the deepest color orange in terms of what they specifically need as they would define it, not how we would define it, but how they would define it, looking at outcomes. So it sounds like you need to volunteer for our measurement subgroup.
There are things I haven't said because I expected that would go to a subcommittee. Yes.
Yeah, okay, all right, great, ready to go. See,
Let
you
the notes.
speak up, volunteer, right? That would be excellent. It'll be a good group, but we'll be able to really look into this. I know, and you're already on it.
Oh, okay. What I find exciting about what's possible with the data is beyond the people in this room and the fact that you said neighborhood,
Yes.
because I'm constantly explaining what I call a Lebanon effect.
Mhm.
Because we're in northern Grafton County, and there is a skew of Lebanon that hides some of the challenges we experience in the north. What I find exciting about the data is beyond what Anna Music can do and what I can do here, is what could be possible at a hyper-local level with a group of people in Dalton, in Whitefield, having a conversation of, are you aware, like here's how it is. What do you see as possible? I think the best solutions come from the hyper-local level. And I think it's risky to do things to or at communities versus doing things with them. You know, so I'm not certain if you sat with a group of people in Whitefield, they're qualitatively aware of how it is. It may be multi-generation, may think that it is what it is. There's nothing we can do, very disempowered. Or they or them will fix it. There is no they or them. No one's coming.
Right.
We're all we have. So I think it's how do we make this accessible at a hyper local level that people can have an aha and see something that they could do with limited resources beyond what we're doing at this table. That's what I think is exciting about it.
And and again, with the equity lens, as we talked about, we'll have a definition of that. Some folks are so stuck because of serious systemic barriers that issues around that need to be addressed, right?
I am loving this conversation
Yeah.
because I think sometimes we are not honest to ourselves when we are in meetings, but this is a reality.
Yeah, it is.
Yeah,
Good.
so.
All right, so this, and we had a wonderful comment here from Patricia or Pat. And Phil, that we use the social vulnerability index, especially when we're doing disease work. It's a different measurement. It misses some of the key things in terms of equity, but we can definitely include that and provide that. It also isn't done as regularly and it's harder to drill down by neighborhood, but absolutely that can be included here. I'm not sure if we can overlap it or not, but we'll look into that. So that's another national measure. That's a good way, especially when you're doing any kind of public health planning, is when we tend to use that. Okay, excellent. Did I miss any other comments? Do I have any hands raised?
Yes, I do.
Okay, but this, all right.
This is halfway. I'm gonna be blunt about my cynicism, but like, I'm not a data-driven person. You definitely do not want me on that committee.
No, you're not invited.
No. I've seen a lot of bad decisions made based on data generation because I live in a world where I see what I see. And sometimes the data matches what I see, sometimes what it doesn't. We talked about stroke rehab and how stroke rehab went a totally wrong direction because the data that they used to drive it was the wrong data. And I just think that doesn't mean you shouldn't be looking at this. I think it's important, but realize that it doesn't explain everything.
Yeah, and that's what Ed was saying. There has to be a way to monitor though, and this certainly will come up with some ways to monitor. Anytime we come up with ways of monitoring, many states use this and that's how they're targeting. We just did a large project in Texas. We're working with Utah, both very conservative states. And it's a place to look at, it's a place to target some things in terms of healthy eating, and we'll hear more about that later when we get into this. So I absolutely agree with that.
I think one of the things that just very quickly to not derail you, but that's one piece here that we've been looking at. But if you walk along the hallway here, there's another way to do it. Like the foundation has tons of stories they've collected over the years of work that's actually going on That's a different kind of data, but it's still powerful.
Okay, Justin has his hand up.
Yeah, sorry. I think, looking at that, comparing it to, the fact that we have an aging population, so throwing an age, potentially a heat map with age on top of it, and then throwing, if just looking at it aside from the Dartmouth area, pretty much all of the areas that are supported by, or that show a lesser score overall are supported by critical access hospitals. So if we're looking at, 3, 5, 10 years down the road, our Asian population is increasing in the need for them to access, the highest levels of healthcare. And we're seeing a change in access to that healthcare. It's kind of staggering, and scary.
Yeah, it is. That's excellent. Thank you. Thank you, Justin. So, and there are other measures that we won't go through now, though the conversation has been good from both folks who use measures and those folks who would rather stay far away from them. So all that is good, but we have an important housing look in terms of that being a root cause. Am I volunteering you for the state? So what do you think?
I'd second that nomination.
I think
So,
we
all right.
should go to that to me.
Come on.
Housing guru, not to volunteer.
All right. And then we really will look at health, we'll look at health status in terms of equity and inequity, because this is like really, really important. And there are some root causes to this, so we'll also look at that. We have to have measurements on health status, so we'll work on that. And then access and use of healthy foods, root cause of many chronic disease, not food banks, that's urgent, but urgent access. But this would be different in terms of supporting health. And there are some innovations happening in this state, and we'll hear more about that. So we'll do just some general measurements, and when we drill down for particular counties and the differences in the blue and orange areas, the innovations that will come from them, and sharing that. So I'm going to actually move on to our exercise, if we can do that today. Hopefully we'll get to that. So what we're going to do is we're going to do an exercise on the whiteboard. So those folks who have computers, this will be fun. I was trained on this, and a 5-minute training ended up doing a 15-minute training, but all right, everyone will do better than me, okay, in terms of using the whiteboard, especially if you've done it before. So the first part of, I'm going to stop sharing. Do you want to call it up? Because then I don't want to describe something if you can't see it. Okay. Okay, so we make the little square bigger? Oh, okay, excellent. So we're going to look here about equitable access. And this was part of your homework and thinking about some very specific things. And this is the part where exactly what Ed and folks have been saying, very specific interventions that you have been doing that are innovative. And Ed has one that's fabulous that could actually go in here, that you're working on right now. So what I'd like to do is take a few minutes and have people add a square in, and actually I can add a square in, and then that will show, or maybe Kristen can add the square in terms of let me see.
So let me say a couple things maybe about how to use this for anyone who hasn't done it before. You should be able to just click N on your keyboard if you're using a laptop, and it'll pop up a sticky note that you can type right in. You can make it a little bit bigger, although we only have so much room, so it's a bit of a balance between text size versus space in the square, but you can always put it in the general vicinity. If you are not comfortable using this or are having trouble, you can also put comments in the chat. And if you don't have a laptop, you're welcome to also just let someone know, and either we can type it in for you, or we can make sure it gets recorded one way or another.
Okay.
Anything I missed with that? From there?
Yep, so you hit on the comment and then put it here. And then you add in your comment, something brief, 50 words or less, joking, 3 or 4 words would be good, and then you can put it here. The other thing is that if you put it around here, stay away from the blue box. If you put it around the green box, we'll also be able to see it. We'll also save this, and this will become part of the minutes. So we're gonna be quiet, put in your little boxes. If you need help, then you can reach out through chat or raise your hand and we'll help you. Oh, here's someone.
Collaborate, then my computer died.
Just sign it, right?
Yeah.
That's
Collaborate.
a good one, Ed. No one has some current intervention? If you're having trouble, you can enter it in the chart and then Kristen will put the post it in for you.
No, I'm happy to.
What if it's an intervention that like my organization doesn't own, but it's happening in our area?
Yes, absolutely, especially if it's innovative, this is something other people could learn, yeah.
Yeah, I think sort of, correct me if I'm wrong, but I think the idea is sort of to brainstorm things you're aware of, things you're working on.
Yes.
Anything like that that's in this sort of topic area.
And if you see something that is fabulous or happening in your area, feel free to put a smiley face, a little thumbs up.
That's good.
Yeah, and another tech detail, I believe if you click on a Post-it note, it gives you an option to sort of put a emoji or something like that as a reaction. So if you want to react to anyone else's, that's an option as well.
How do you click something?
No, you already.
Post-it note, just use the pen.
Oh.
Oh, this is.
Are these programs or these concepts?
No, things that are actually happening.
All right. But if it's a deficit.
No, the deficit goes under specific, the other side, but we haven't done that yet. Who's playing that? Don't touch the main box.
Someone just took my sticky, so I was trying to find it back. Causing chaos.
Come on now, people.
Adults do.
Sorry, that might have been me. I apologize.
Holly, stealing the stickies again.
Thought it was mine.
Enhancing.
Oh, here's one you want to put down? Yes. That one. That's a real good one.
No, it's a group work, so you have the credits, it's a reality.
So while you're waiting for everyone else, for the deficit areas are really things you've seen in your wheelhouse, in your community, of things that really impact equity under health status and health outcomes. So if you would just add that in there while people are struggling with the technology.
That's a transition lenses aren't quite getting the job. Need a bigger screen.
And you can,
You need to move to the,
yeah, but
We'll just sit here with.
we can-
Oh, Someone just made one disappear, okay.
Yeah, those are the meeting people's ideas.
Somebody made a deficit disappear?
Somebody's got, that happened
Somebody's
live.
got pixie dust.
I love it, this is great. Oh, no, there's some below, how can we do this?
Click, drag, drop.
Yeah, you have to click in an area of the sticky note that is not text and not the edges.
Yeah. I know.
Which can sometimes be hard to find depending on how loquacious you were with your writing, so.
I also found click and then use the arrow buttons.
Yeah, okay.
Okay, yes.
Because I was not able to.
Justin, I'll put the one in for you. Yeah,
Thank you.
so I want to say,
I'm working on the one from Josh.
And it changes to enhance.
you can, tell me if you want me to edit this, Justin, I just wrote it in.
It's much more complicated.
It's a high-tech version of the chart.
Somebody's got a quote too.
Really?
You really
Yeah.
Yes.
Relationship called murder.
I wrote my kids and that focus on so now the kids go through different level, I go through different.
Okay, what do you think? Justin, how's that? Is it big enough?
That's good, thank you.
That's it, yeah.
How are we doing? I'll give folks one more minute. If you feel like you want something in there and it's not working.
And I'm working on transferring the ones that are in the chat, so if you don't see it yet, you will.
What's this big giant one?
I'm trying to get this little white one deleted.
This
Because
one
it
right
went in the
here?
wrong place, this little tiny white one,
Under specific deficits?
under deficits, yeah,
It's like a little bubble.
that one.
Okay, so I did it.
That should be, I put it in the current planned interventions, but I already, it should be deleted.
Oh, it's already.
It's already there, yeah, thank you.
Of
Just
course,
couldn't move it.
it's not surprising in any way. Surprised you didn't do that before now.
All right. Oh,
Comment
wow.
on it. That's
Gee,
great.
look at this. I'm so excited. Good job. There's some great things here. And we're gonna solve it and discuss it in 15 minutes.
Yeah.
We'll
In
have
that
to
order?
come back. Yeah, right.
If you want to move on, I can make sure that the remaining ones in the chat get captured.
Yeah.
After the meeting.
Right, I know, all right. So we could move on, and of course, we have this broken down to the other areas, which we will pick up on at the next meeting after we handle a few definitions. I don't think we may have a report from the subgroup, so. the data group, which will be great, that'll be fun. So the purpose here is to really look at what current planning is going on in terms of, it could be a pilot, it could be a promising practice, it could be an evidence-based intervention that you're trying in your area. Something that is going to address equity, access, or the improvement of health status and health outcomes. So not necessarily a statewide effort. Again, this is exactly within your wheelhouse or county. Does anyone want to share one of the ones they put in here? Where all of these will be here. Oh my goodness. You're very excited about that.
I am actually.
All right, so we have dental clinics and Head Start centers. Whoa, that's a big one. Who put that in there?
Sorry about that. That was me, Beth Daniels over at Southwestern Community Services.
And this is something that's going on right now?
It is. It's a collaboration. We received a small grant from Delta Dental And we also have been able to utilize some other community resources to partner with some of the local dental hygienists. And basically it provides the dental screenings for the children, but also provides additional actual services that would normally be billable through Medicaid. And we've been able to earmark a little bit for chair time for parents as well, for chair time with the dentist. And it just helps them establish that dental home. And so, yeah, it's been really successful.
So Beth, is this the only site in New Hampshire, or are there other Head Start locations that are doing this?
We have 5 Head Start centers between Cheshire and Sullivan counties.
Okay.
So we are working on that throughout ours. I know many Head Start centers around the state have different types of health initiatives that they're involved in. But that's one that we're kind of focusing on. The opportunity was there, so we kind of jumped on it.
So that is perfect, right? Under health, health equity and health access. That's an excellent example.
You go Delta
Yeah.
Dental.
Pardon?
Said go Delta Dental.
I know, really, and I'm surprised on this. Okay, excellent. And let's see, who else wants to share? We have some really excellent things happening here. Ed, do you want to talk about your mobile
Sure.
teaching kitchen? Because that is evidence-based. That's fabulous.
Yeah, this was initially funded with supplemental funds from HRSA for a demonstration, about $50,000. So there are 2 portable teaching kitchens, and the concept is within a broader food as medicine framework, which is national. And when we have patients spend time with a nutritionist or a registered dietitian, they often spend time talking about food. Yeah, we don't often go the next step of actually prepping food. So this is a one-on-many approach to be able to get out into the wild and set up a teaching kitchen and share a meal. Ideal in it is 30 minutes from prep to plate, trying to keep the ingredients minimal, trying to be sensitive to the economics of food, and have people taste the food, enjoy the food, and then as a quiet footnote, oh, by the way, if you happen to have diabetes, this is the carb load. This is why it matters. If you have hypertension, you notice we didn't cook with the salt. You said you liked it. This is the sodium one. So rather than a full force nutritional, no one ever picks a restaurant for carbs and sodium. Says that was the best low sodium restaurant I've ever been to. Said no TripAdvisor review ever. So it's really a different way. And when I think about equitably, and I've had the pleasure to travel a lot, you almost always end up in people's kitchens. So someone who likes to cook, it's hard for you to get you out of the kitchen. So food is a common, independent of ethnic and racial and other sorts of factors. People come together around food. So I think it addresses the how piece of the food. And I'll have collaborating partners to get the food. And when we get to the North Country with an older population, a value added is it may positively affect social isolation and bring some people together. It has the potential to be multi-generational. We'll work with the White Mountain Community College, has a culinary program, and we're doing the videography work with Northern Vermont University, so we can start to collect a cache of videos that I think increase the accessibility beyond the written word to seeing, oh, it's really not that difficult. It didn't take me that long. I've never tried that food before, but I really like spaghetti squash. And I have diabetes, so the carb load is different. So we have 3 years. The end game is in 3 years from now, we'll have 5 portable teaching kitchens from roughly across Route 25 and all the way up through the Canadian border to put out in, I call it being out in the wild outside of our healthcare facility. It really will take a community and a bunch of collaborators. We bring a piece of the solution, but we're not solving the food piece per se. It's just a segment of it. So it's exciting.
Yeah. And for funding, NIH just funded several places in Texas and Utah and some of the states that are working with in terms of this whole notion of getting access to healthy food and reconnecting about how to make that healthy food that's culturally appropriate. And it really is, it's really taking off. It's a root cause in terms of some illnesses. And so that's very, very impressive. There are so many, anyone want to mention theirs? There are so many fabulous things here. I don't want to just pick someone and then piss someone
Dave
off.
had his hand for a long time.
What?
He had his hand for.
Oh, what's yours?
Oh, all right. Well, Ed's very familiar with this one, but I really would like feedback from all of you on this one. But one of the worst things I've seen in healthcare over the last 35 years is the progressive siloization, fragmentation, things like that, where people provide services or don't provide services and we can't provide them in a unified, integrated manner. So what we did was we created an integrative program that we're starting to look at how do we provide pain care to people in this state by using community resources, bridging silos. That was the whole point of it. What I found out was that hospice already does this, but palliative care can't because they can't get reimbursed for it. So what we want to do is create models of reimbursement for programs like that that bring different people together in a community to solve a complex problem. I was excited because people all over the country are interested in it. As far as evidence bases, we've known that this model works since the mid-1980s. There's plenty of data to support it. The next question is why? And that's when we get into like about a 7-page list of barriers that we need to break down that jive very well with what this group is looking at, because our hope is that we go beyond pain to look at other issues as well. Addiction, mental health, all those kind of things. So,
Yeah, I think we discussed physical pain, psychological pain. When I worked in home care, root cause analysis is they wanted to decrease falls, which is hugely important and it's still a big challenge and important. What we realize is that falls was an outcome, not a cause, and we needed to address pain. Because pain is a precursor for pain that limits our activities of daily living and independent daily living. And we are more at risk of falls. When I apply fall statistics against our 1,600 patients in the Medicare, I get 10 to 20 hips, $1.5 million, and I didn't count the toe tags and body bags. So it's as an aging population. I didn't discuss it here, but we're working with David and thinking about, you know, people have decreased pain, the functionality increases, the functionality, the muscles and bones, they'll maybe fall less frequently.
what I liked about this project the best was empowering people that are not currently empowered, like alternative providers. One of the things that we did was we created support groups that are run by people for free that have lived experience with the problems that we're dealing with, and they can provide valuable services. And there's a lot of that in this community that we really need to find.
So we're actually gonna have to wrap this up, but we are going to sort of make this, we're gonna make this list of both of them. And then we'll take another look at this, besides the other things we agreed to work with. So what we need to do now is actually, okay, so we're actually going to go now to public comment. We need to do that. Does anyone who has joined us have some comments that are a usual part of the board? Sorry, advisory council. Yes.
So I just wanted to say thank you guys, because today is my first day actually in this meeting, and it's hard to say because nobody can replace Ben. So Ben left New Hampshire housing. I'm talking about Ben Frost. Yeah, for Rhode Island housing. So we are now trying to see everything that Ben was involved in, how to assign those important works that he was doing. So I just want to say thank you for inviting me. Last time I couldn't be here because I was in Phoenix, Arizona for a meeting. So I'm very honored and delighted to be here with you guys. As I said, this is very important to all of us, and many of us, it can be even personal when it comes to community that we represent. Thank you.
Thank you, welcome. Yeah, Subcommittee on measurement, okay, got it.
Wherever you see fit.
Okey dokey. Let's see, in the chat, do we have folks that?
No more comments in the chat currently.
Okay. Hey, so the next steps, we're trying to get done on time. I apologize for that. However, really, really good discussion, and we'll bring this forward to the other parts. And again, this is the biggest domain, at least we think it is. Take a moment, please, and complete the evaluation, 3 minutes. Sir, and it'll be in the chat, you just have to click on it. We will send a survey out this week regarding a potential meeting where we could have a quorum in the spring, where there won't be bad weathers and maybe bad weather, and you can look at your schedule and see what will work and see what we can come up with. So slides and minutes will be out the next day, you'll have that, and then we said we were gonna do this grid based on everyone's input. And then folks can add more to that, it really wasn't enough time, and then we really want to hear about what folks are doing in case it's applicable to other parts of the state, which was a key point, I think, here today. Kristen and I will be reaching out for your individual meetings, and those folks who we've already met with, totally impressed, fabulous. They were really, really good to talk with you. And then, of course, I've only mentioned it, how many times I mentioned it? 25 times? The measurement subcommittee volunteers will be reaching out to you, depending on what your title is. We'll be reaching, anyone can come to any meeting and anyone can join with that. We have 2 of our next meetings, again, based on the survey. We're just trying to choose a time that is good for everyone. So Monday, the 18th of November, same time, same place, except we didn't get this room, we got the Snowy Owl room. And then on the, in December the 16th, same time. And then any wrap up comments, chair and co-chair? What do you say goodbye to folks?
No, thank you. I'm really looking forward to making this real. It's important.
Yeah. Ed? That party word?
Buy a Subaru, just saying.
That helps for traveling, okay. Subaru is not a sponsor, we have really with Subaru, remember, this is being recorded.
I actually do have one more comment.
Oh, no Subaru.
The minor detail is I can only be chair if I get reelected on Tuesday, which is a minor detail, and then I have to be reappointed by the speaker, which is another, I think, less minor detail,
Okay,
but,
yeah.
so I might not be here after Tuesday, but we shall see.
All right, it's great, that is not a campaign message or request for votes, okay, great.
Information.
But it's a reality check.
All right, okay, we appreciate it and hopefully you will be here. All right, anything else?
Thank you to the Brandeis folks.
Yes,
Thank you, everyone, we can say goodbye and we'll be in touch soon, thank you.